Bismillahirrahmanirrahim. Let's see the abnormal labor. So, if you look at the normal labor, so there are three components which contribute in the normal labor. One is the passenger, other is the passage, the third thing is the power. Here is the passage, which has two components: bony pelvis and the soft tissue, and the passenger, which is fetus, and other component are umbilical cord, placenta, membranes, and the amniotic fluid. Okay. So, and in the power, so there are three power are provided. So one is the uterine contraction, other is the fetal excess pressure, okay, and the third is the auxiliary forces, mean the woman bearing down power, okay. So these three power actually help to fetus to come out of this passage. If you look at the uterine contraction, so there is a sequence of the contraction and the retraction, which help the baby come out of the birth canal. Okay, so if you see here, so this part is contracted now, and in the next step, this is retracted back, and this next part is the contracted. Okay, so this is contracted, and this is part is retracted. So this uterine contraction occur in the upper segment. Okay, so there is contraction and the retraction, contraction and the retraction. Okay, so this help the baby come out of the birth canal. Let's see here. Okay, so now this baby is coming out of the birth canal. So this is the passenger, this is the passage. Okay, and this is the power, uterine contraction, fetal excess pressure, and the auxiliary forces, mean the bearing down power of the mother. Okay, we cannot change the passenger, we cannot change the passage, but only thing which we can increase or decrease is the power, that is the uterine contraction power. If any problem in the passenger or the passage or in the power, so this lead to the abnormal labor. Okay, what is the abnormal labor? There would be a precipitate labor disorder, mean the faster progress, mean the complete labor occur less than 3 hours. Okay, so this is a precipitate labor. Okay, faster progress. This is usually in the multipara, or if there is small fetus or the roomy pelvis, or there is a strong contractions. Okay, that is more than the normal contraction. Or the prolonged latent phase means slow dilation. Okay, or the protection disorder, which is a slow progress, mean the protection means slow. Okay, so this is a slow progress of the either the first stage or the second stage. Okay, this slow dilation and slow progress occur in the CPD, mean the cephalopelvic disproportion or the dysfunctional uterine contraction, like hypo or hypertonic uterine inertia. Okay, and the arrest disorder mean there is no progress at all. Okay, either in the first stage or in the second stage. So these are different types of the abnormal labor. The precipitate labor mean faster than the normal. Okay, and the prolonged labor means slower than the normal, the time for the normal labor. Okay, protection, that is also slow progress, and the arrest disorder mean no progress at all in the either in the first stage or the second stage of labor. Okay, so this is occur usually in the fault in passenger or passage or power, which is in the CPD case. Okay, if you look at the normal labor stages, okay, so here is the cervical dilation, on this side is the time in labor. Okay, so if, you know better, the first phase is the latent phase of the first stage of labor. Okay, and then the active phase of the labor. Okay, so and the active phase have also three parts: the acceleration phase, maximal slope, and the deacceleration, and after that is the second stage. Okay, if you look at the station, that is -5 to +5 stage. So 0 is the engagement stage. Okay, so here you can see as the dilation increases, so there is a descent of the fetus. Okay, so station reaches up to 5. Okay, so this is the normal slope of the labor. If you look at the abnormal labor, if the labor lasts less than 3 hours or more than 24 hours due to abnormalities in the passage or the passenger or the power of uterine contraction, so this is known as the abnormal labor. Now look at the graphical representation of abnormal labor. So on this side is the time, on this side is the cervical dilation. This is the normal slope of labor. Okay, what is happening in the abnormal labor? So this is the precipitate labor. mean the whole process of the labor occur less than 3 hours. Okay, so this is known as the precipitated labor. Okay, now look at this curve. This show the prolonged latent phase in the nullipara if it occur more than 20 hour, or in the multipara if it's more than 14 hour. This is known as a prolonged latent phase. Okay, so if you look at this curve, so what is happening here? There is active phase arrest. Here you can see there is a normal latent phase, and then in the initially there is the dilation of the cervix, but after that there is the stop of the further dilation. So this is known as active phase arrest. Okay, in the first stage, no progress in the cervical dilation more than 4 hours. This is known as the active phase arrest of the first stage. Okay, this is another curve. We show the active phase protracted, mean which is slow, although there is the dilation, but it is slower than the normal. Okay, so in the nullipara, if it's less than 1.2 centimeter per hour dilation, in the multipara less than 1.5 centimeter per hour dilation. So this is known as the active phase protracted. So this graph summarizes the abnormal labor associated with the first stage of labor. Now look at the abnormal labor associated with the second stage, which is especially a descent of the fetus. Okay, so this is here is situation, here is the cervical dilation, on this side is the time. So this is the normal curve of dilation. This is show the cetacean or the descent of the fetus. Okay, so now look at the abnormalities or the abnormal labor. So this is the second stage arrest. I mean there is no further descent of the fetus. So this is the second stage arrest. Okay, when there is no descent more than 3 hours in the nulliparas, and more than 2 hours in the multipara, but add one more hour if you have given the epidural anesthesia in the nullipara as well as in the multipara. Okay, now look at the slow progress of the second stage. Okay, although there is a descent, but it is slower than the normal. Okay, so if in the second stage delay in the progress more than 2 hours in the nullipara and more than 1 hour in the multipara. So this is known as the second stage protraction, and this dotted line represent the complete failure of the descent. Okay, so this summarizes the abnormal labor associated with the second stage. Okay, so now compile both the first stage and the second stage. Okay, so this is normal dilation. So this is a protracted, mean less than 3 hours. Okay, and this is a prolonged latent phase, mean more than 20 are in the nullipara and more than 14 are in the multipara. So this represent the active phase arrest. Okay, and this represent the active phase protracted. Okay, and here if you look at the second stage. Okay, so this is normal descent, and here is the arrest of second stage, and here is the second stage protected. Okay, and here is the failure of descent. So this is the summary of the abnormal labor. Okay, here is the diagnostic criteria we already discussed, and here is the optional treatment in the prolongation disorder, bed rest, and then you give the oxytocin. If it's not further progress, then you go for the cesarean section. Okay, and in the protraction, so expectant and supportive therapy is preferred. Okay, and if it's not progress, especially in the CPD, we go for the C-section. Okay, and in the arrest disorder, so we have laid for CPD, and of course if there is CPD, you go for the cesarean section. If there is no CPD, you give the oxytocin and give rest if the mother is exhausted, and go for the cesarean section. Okay, now look at the etiologies and the complications associated with the precipitated labor. In the etiologies, you know better, multipara, small fetus, roomy pelvis, or strong contraction lead to the precipitated labor. Okay, and the complication in the maternal are the laceration of the cervix, the purpurum sepsis, okay, or the postpartum hemorrhage, and the fetal fetal birth injuries can occur due to precipitated labor. Okay, what is the management? If before delivery you give the epidural anesthesia, okay, and which slower the progress of the labor, and you should also take care of the perineum, so give perineal support in the especially in the second stage, okay, to prevent the perineal injury. And if the delivery has occurred, you should explore the birth canal for laceration and give antibiotic prophylaxis. Okay, and neonatal exam for the birth injury. Okay. Now look at the prolonged labor, which is delay in the progress. If there is a less dilation, mean what is the less dilation? Mean less than 1.2 centimeter per hour dilation in the nullipara and 1.5 centimeter per hour dilation in the multipara. And in the second stage, if it's longer than 2 hours in the nullipara and longer than 1 hour in the multipara, so this is considered the prolonged labor. Okay, but in case of epidural anesthesia, you should consider 1 extra hour. In the etiology, the number one is the CPD, mean the cephalopelvic disproportion. Here is the pelvis, and here is the cephalic part of the fetus. So if it's not appropriate, and this lead to the prolongation of labor, and eventually it lead to arrest of labor. And in such case, only solution is the cesarean section. But in case of a dysfunctional uterine contraction, I mean if there is a hypo, you can give the oxytocin, and if there is hypertonic, you should stop the oxytocin. What are complication? Maternal exhausted, and the puerperal sepsis, okay, and the postpartum hemorrhage, the fetal distress, or the asphyxia. Okay, so these are the complications associated with the prolonged labor. Okay, what management, as you mentioned in the CPD, cesarean section. If hypotonic, amniotomy or the oxytocin augmentation, so this increase the contraction, so this faster the labor. Okay, in case of a hypertonic, so you should stop the oxytocin, give IV fluid or the epidural anesthesia. This normalize the labor progress. Now look at the obstructed labor. In the arrest, there is no progress in the cervical dilation more than 4 hours, and in the second stage, no descent more than 3 hours or more than 2 hours in the multipara. And extra hour if you have given the epidural anesthesia. The rest of labor, so this is usually due to CPD. Although there are strong uterine contraction, but there is no dilation in the first stage, or there is no descent in the second stage arrest. Okay, so CPD mean cephalopelvic disproportion. What are component associated with the CPD? Mean fault in the passenger, or in the passage, or in the power. Okay, here you can see the fetal macrosomia, in the large fetus, okay, which is unable to cross through the birth canal. Here you can see there is obstruction in the passage, so this arrests the labor. Okay, and here you can see there is a contraction ring which is around the neck of the fetus. Okay, so this prevent the progress of the labor. Okay, if you look at the common fault in the passenger, just remember 5M. Okay, number 1M is the male presentation, like face, burrow, or the breech, or the shoulder presentation. Okay, in the male position, like OP position, which is abnormal position. Okay, and the macrosomia mean large size fetus, and the other M represents the multiple fetus, which are log, especially the log twins. Okay, and the male formed congenital anomalies like hydrocephalus or the congenital twins. So these are the fault in the passenger which obstruct the labor. Okay, and if you look at the fault in the power, as I mentioned, so there is a contraction ring around the fetus. Okay, so this obstruct the labor. And in the fault in the passage, so there are some bony component and there are some soft tissue component. In the bony pelvis, like contracted pelvis inlet, mid pelvis, or at the outlet, here you can see the contracted pelvis, which do not allow the fetus to come out of the birth canal. Okay, and the abnormal shape like android or the anthropoid pelvis. Okay, and the pelvic bone tumors. So these are the fault associated with the bony pelvis. If you look at the soft tissue problem, uterus, there is a fibroid or the cervix stenosis, dystocia, carcinoma, or the placenta previa centralis. Okay, and in the vagina, so if there is stricture or the undilatable stenosis, congenital septa, and in the vulva perineal, so if there is a rigid perineum, or the hypoplasia in the vulva or the perineum, and edema or hematoma, so and the tumor, ovarian tumor, vaginal tumor, other pelvic tumor. So these are different components associated with the soft tissue, which are the faults in the passage. So this lead to the obstruction of the labor. Okay. If you look at the clinical picture of obstructive labor, so there is a generalized dehydration and the exhaustion of the mother, and in the abdominal examination you find the pathological retraction ring or the Bender ring. So in this picture you can see doctor is trying to assess the CPD. Okay, so what is Bender ring? So there is the thickness in the upper segment of the uterus and the thin lower segment. Here you can see, so this upper segment is thicker and the lower segment is thin. So this is known as the Bender ring. Okay, and in the pelvic examination you find the capet in the fetus head. Okay, and the dry vagina, the edematous, and the fully dilated cervix, but the station is -2 or -1. Okay. If you look at the complication of obstructive labor, so there is a risk of the uterine rupture. Okay, but in the paramic gravida, so there is a uterine atony, but in the multigravida, so there is a risk of the uterine rupture. Okay, and obstructive labor may lead to necrotic vesicovaginal fistula, the postpartum hemorrhage, or the purpurum sepsis. Okay, in the fetus, so there is a distress or the asphyxia. Okay, and the management is only C-section, no instrumental, as their head is not engaged. It's a -1 or -2 sedation. Okay, this is all about the abnormal labor. So here is the summary of the abnormal labor. Okay, thank you very much. Allah Hafiz.